So ocular surface tumors we know can be a lot of different varieties. Some can be benign, some can be malignant. The malignant ones at least are, if not more common, at least are as common as the benign tumors, unlike any other part of the body. So some of them can be congenital, some of them can be acquired, some can be pigmented, some can be non-pigmented, which actually makes the diagnosis quite confusing. So if you look at some of the lesion, if you again go by the colors, the pigmented lesions can be something like a nevus, spam, melanoma, or even congenital ocular melanocytosis. And in the non-pigmented lesion, again, we have a host of lesions, the most common being the malignant ones, that is the ocular surface squamous neoplasia. Other than that, we have lymphoma and the benign ones like dermoids, lipodermoids. So why is it important to recognize the ocular surface tumors early? Because the spectrum is quite a varied one. They are mainly locally invasive tumors. Unlike the other ones like the intraocular or maybe the eyelid ones, they are very slowly growing tumors. So if you're able to catch them a little early, is going to make a lot of difference in terms of prognosis. It's almost curable if you're able to catch them early and treat them at an appropriate stage. And since the spectrum is varied, their presentation is also quite varied. So misdiagnosis is quite common for these tumors. So we start with something as simple as that. The diagnosis is quite clear-cut here. This is a young girl who has this pigmented lesion, which the parents say has come up in the last few years only, and it has been increasing in size, and they are mainly concerned with the cosmetic aspect of it. So it's like almost a flat kind of pigmentation in the perilimbal area, light brown, with a little variegated appearance, little variable pigmentation, and seems to be on the conjunctiva, and it's mobile along with the conjunctiva, not attached to the underlying episclera or the sclera. So this is a conjunctival nevus, which is quite commonly seen in our clinics, which are usually benign unilateral lesion, does not really progress, and most of the time the treatment is required for the cosmetic purpose. What about this patient? This was actually sent, this was again a young boy in his teens, about 14-year-old, who was seen, and the treating ophthalmologist actually has advised an immediate biopsy for this lesion because they were told that this is a malignancy because of the color of the lesion. It's a very little darker brown lesion, seems little elevated, especially the central part, and also it seems to have a lot of feeder vessels, which again is supposedly a sign of malignancy. So this was actually again a conjunctival nevus. So conjunctival nevus need not always be flat, need not always be light brown colored. It can be different colors, starting from something like this, where the central part is more pigmented. A color which is more darker, almost looks like a melanoma with a little small satellite nodule here also. It can be amelanotic, very light brown colored like this, or it can be in atypical locations like this. So the clue to the diagnosis is to have a good slit lamp evaluation for this patient, and if you see this patient under slit lamp, we'll be able to appreciate the cystic spaces which are usually there within this lesion. So presence of the cystic spaces are usually almost diagnostic for this lesion. Nevus can at times, during the time of puberty, they can actually increase in size a little bit, and that's the time when most of the patient actually comes to us, that this lesion has been there for a long time, but now it is increasing in size. It can get inflamed a little bit during that period also, so it gains a lot of vascularity. Some feeder vessels can also happen around the lesion, so that seems to be a warning sign for most of the parents, and that's the time they come to us. So on examination, if you find that there are these cystic spaces diffuse within the lesion, so we can safely conclude that it probably is a nevus only, and not really melanoma, though very rare, maybe less than 1% of cases of nevus can actually undergo transformation to melanoma over a period of time. So if there is any doubt, there is no biopsy has to be done, and or otherwise we can keep the patient on follow-up if the patient is not keen on surgery at that point of time. So it says that nevus is suspicious if within that area of flat pigmentation you are developing some nodular areas, something like this. This was quite gross. By the time the patient, he had this pigmented lesion right from early childhood, but now over the last couple of months this nodular area has come up. It has some hemorrhage over the surface. It seems to be pedunculated, attached to the main lesion, which is here, which is again thick, almost uniformly dark brown colored. So there is no doubt that this is a nevus, this is a melanoma, conjunctival melanoma, which is arising out of a nevus. So most of the time the textbook says that if a nevus which is a larger size, say about more than a centimeter in size, if there is any recently documented growth in a nevus, there is some change in the color, presence of feeder vessels, if it's recurrent, these are some of the points which are usually given in the textbook, that there's a time when we should be suspicious that we are dealing with a melanoma, not a nevus. So going by this criteria, what about this patient? He was again a young patient in his mid-20s, who again gave a history that he had this lesion for some time, but now it has actually increased in size quite a bit. And this looks quite gross. It's almost involving half of the bulbar conjunctiva, looks quite fleshy, it's thick, uniformly colored again. But the overlying conjunctiva seems to have some chronic changes of scarring and all, which again tells us that this is something which has been going on for some time. And we also thought it could be a melanoma, and this went ahead for excision, but to our surprise, it turned out to be a nevus only, a little atypical variant of nevus, also known as giant nevus, the balloon cell nevus. So it's not that all these criteria, if they are present, a larger nevus, if you see, is suspicious or it is actually malignancy, but probably more important are a documented growth, a recent growth, which we are able to document throughout serial photographs. If it's recurrent, if it has been excised once and the tumor comes back, then probably it's more likely to be malignant. And definitely if there are some fleshy nodular areas which is coming up within this lesion, these are probably short signs of malignancy and needs to be treated. Another patient, again in his mid-20s, who was again seen in the hospital, and he was referred to us with this, basically he had a painful blind eye. So he was diagnosed as a case of staphyloma, intercalary staphyloma, painful blind eye, absolute eye for some reason, and he was basically bothered with the cosmetic aspect of it and for the pain management part of it. So he has this, again, a jet black sort of pigmented lesion on the conjunctiva, but what is else is there is this small areas here also where there seems to be a small staphylometer sort of appearance. He has a shallow SC, he seems to have some BSK, which indicates that something chronic is going on, and it's not very appreciable in this photograph, but if you look at the iris, it's again a jet black color. So this was actually a case of uveal melanoma with an extraocular extension, a long-standing one, where the tumor is actually eroded through the sclera, the limbal area, which is one of the weak areas, and it has come out of the eye. So a CT scan and B scan confirmed the diagnosis, and this patient finally had to undergo an enucleation followed by adjuvant treatment with radiation and a metastatic workup. So going again by the pigmented brown lesions, this is a young girl, she is in her early 20s, who again comes with this recent onset pigmented conjunctival lesion. Now this is again flat, this is little more dark brown colored, but this is more diffuse, unlike the nevus which we have seen earlier. Like he almost has small specks of pigmentation all along the limbus, almost for about 3 to 4 clock hours, and rest of the area seems to have specks of pigmentation. This part is more darkly pigmented, little more elevated maybe, but looking on the scleroderma, we also found some pigmentation which are there in this part also. So this was probably not a nevus. The history was short. The patient also showed the old photographs, which shows that she definitely did not have this lesion 2 years back. So this is something which has come up recently, something more diffuse. Not a very localized lesion. So this is something which is known as primary acquired melanosis. Not very commonly seen in this age group. Probably the age group is little elder, but at times we can see it in younger patients also in their 20s and 30s also. So it's important to recognize PAM because PAM has a predisposition to undergo malignant transformations, which nevus probably, the chances are less in nevus. So PAM again these are again flat, they are mostly unilateral, they are diffusely pigmented lesion, and most of the time the pigmentation is irregular, as I showed in the previous photograph. Unlike in nevus, which is much more localized. Mostly in the middle age and elderly, most common site are the inferior fornix and the inferior lobular conjunctiva, and we actually have to differentiate it at times, especially in our kind of setup, from the racial melanosis, which is quite commonly seen in people which are darkly pigmented, but racial melanosis is going to be more diffuse, more along the perilimbar, and usually is going to be bilateral, unlike a PAM, which is usually unilateral. So importance of PAM is that if you identify a lesion to be a PAM, the patient needs a biopsy. If it's excisable, it's better to excise the lesion completely. If not, then we need to do an incision biopsy, a special type of incision biopsy, which Vikas has spoken about, the MAP biopsy. And we have to send the specimen to a good ocular oncopathologist who has experience in seeing those kind of lesion. Because they have to differentiate on histopath whether this PAM has features of atypia on histopath or whether this does not have any features of atypia. If there are features of atypia in histopath, there is a 50% chance that this PAM can over a period of time undergo a malignant transformation into a malignant melanoma. So this patient needs to be treated promptly and needs to be kept on close follow-up. Whereas if there are no features of atypia, then we can safely kind of give the prognosis to the patient, and more detailed or more close follow-up might not be required for this patient. So this is one of the patient who had this pigmented lesion. He had this PAM, plus he had this PAM can involve the periocular skin also. And now this has been there for a long time. Now when that's the time when he had come to us, when he had developed the nodular area. This was an amelanotic melanoma which is arising out of PAM. So anything which is more than 6 millimeter in size, or if there is any presence of nodule within an area of PAM, that's the time we need to be suspicious that this probably has already undergone a malignant transformation and institute the treatment promptly. So when to biopsy a PAM? If the lesion seems to be an atypical site, something like this, palpable conjunctiva, little amelanotic, more larger in size, more than 6 millimeter or so, in the fornical area, so there's a time when you need to biopsy this lesion. If it's localized, we can just do an excision biopsy, and if there seems to be some scattered pigmentation even in the other part of the conjunctiva, then it's better to go ahead with a map biopsy for this patient who had some pigmentation here also. So map biopsy is like where we take out small pieces from the perilimbal conjunctiva, from the fornical, from the palpable conjunctiva, 3 sites, and also from the caruncle. So about 18 sites, small pieces of biopsy, about 3 by 3 millimeter. They're stuck on the filter paper. They're labeled. The same diagram is made on the OT note sheet, so that when the pathologist tells us, okay, number 1 is positive for ATPR, we should know like number 1 is from which site, caruncle or bulbar or what conjunctiva. So this is what map biopsy is, and in PAM it's suggested that, especially if it's a diffuse kind of PAM, we should go ahead with a map biopsy. So this is again a melanoma which was arising out of this area of PAM which the patient had, and this is fleshy, and at this stage there is again no doubt about the diagnosis. So I'll skip the melanoma part of it because this is more of a management, and go to the OSSN, another big masquerade in ocular surface tumors. So OSSN, we all know, again, are the slowly growing tumors. They are, again, very low-grade malignancy, except for a few histopath variants, which can be a little more aggressive. So most of the time they metastasize. If they have to metastasize, especially in the late stages, first of all, they go to the lymph nodes. And till that time, actually like the threat to the life is not as much as other tumors of the eye. So it's important to diagnose them very early and able to eradicate the disease completely. Typically, these are the variant of OSSN which we see in our clinics. A very gelatinous sort of nodule which is usually there in the limbus with some feeder vessels. A papilliform appearance which almost looks like a papilloma but much more bigger in size. The location wise it's in the around the limbal area, where the normal papillomas of the conjunctiva is usually in the fornical area. Or a lesion which is again nodular with a lot of white keratin on the surface. So these are the 3 common variants, the typical variants what we see in the clinic. The gelatinous, the papilliform and the leukoplakic. What we do not commonly see, or what are the variants which are commonly misdiagnosed, are this one, the atypical OSSN. So let's look at the atypical features of this lesion. Like this gentleman, again a young middle-aged patient who was being treated for keratoconjunctivitis for some time. Allergic, treatment was in lines of allergic conjunctivitis or a keratoconjunctivitis. And because he used to have this limbal lesion, little erythema with some blood vessels here and little bit of opacity which seems to be going towards the cornea. But over a period of time, almost he was on treatment for almost an year, but he did not respond to the treatment. This redness used to keep on coming recurrent. If you look at this photograph closely on little higher magnification, if you see the lesion, especially this part, this seems to have the part which is towards the pupil seems to have the fimbriated edges. And if you look at the limbal area, there seems to be some blood vessels which are within the lesion. So a keratoconjunctivitis, if at all, there has to be some blood vessels. It should be some like superficial corneal vascularization, that is what we see. Whereas this one was small twigs of intrinsic vessels which are within the lesion per se. So this was not a simple benign thing which we are dealing with. So this is a variant of what do you call it as a corneal OSSN. A little atypical variant, not very commonly seen, but if you see it in the clinic, especially these fimbriated edges and some amount of, at times we can see a limbal nodule which was not there in this patient, little more flat appearance, but sometimes a keratinized limbal nodule can be seen in this patient from where the tumor arises and then goes towards the cornea. So these patients can be treated quite, the treatment is quite simple. We just need to do an excision. Here there is going to be a scraping of the corneal epithelium, and if there is a limbal nodule, then that part also needs to be excised. Along with giving adjuvant treatment with cryotherapy and if required topical mitomycin also. Another patient, he was again a very elderly gentleman, about 75 years old. He was being diagnosed as herpetic ulcer, viral keratitis, herpetic corneal involvement, and was being treated on the same line for a couple of months down the line. But he used to keep on getting these recurrent symptoms. So these are a high magnification photograph. This is the time when he had come to us. It almost actually looked like, if you look at the slit lamp, almost like an, fimbriated edges look like almost like a dendritic linear sort of thing, dendritic sort of ulcer. And because it was, some part of it was actually staining with fluorescent also. And what was missing here, what was probably missed was this nodule which was there at the limbus, which was a white keratinized nodule. So this gives us a clue that this is OSSN which we are dealing with. This is a nodule from where actually the tumor has gone towards the cornea, and there are small specks of keratin even on the corneal lesion also. Another variant of OSSN, the diffuse OSSN variant, where we do not see any nodule per se or a mass per se, but there is a diffuse thickening of the whole conjunctiva, almost like a chronic conjunctivitis, again which does not respond to your conventional treatment. So any persistent unilateral blepharoconjunctivitis, if is not responding to the conventional treatment, we must think of some other pathology, and biopsy is required for this patient. This was another patient which we recently saw in the clinics. This lady was actually being treated as a Murren's ulcer. She has some area of even scleral thinning here. There is a corneal thinning here, almost about 4 to 5 clock hours. So this was diagnosed as a Murren's ulcer. She was an elderly lady because of some associated systemic autoimmune disorder, and was being treated on the same line. But she continued to have this persistent redness of the eye. So what was probably missed here was, if you see here, the lid, if you do not retract the lid, there seems to be something here which is elevated with some specks of white spots here. Seen better in this photograph. So she has this nodule here with specks of surface keratin. So this was actually a nodular variant of OSSN, the mucoepidermoid variant, and with diffuse involvement of the remaining conjunctiva also, which presented like an diffuse conjunctivitis. So OSSN can actually present like a Murren's ulcer. Another variant of OSSN, the gelatinous variant, which can sometimes go just along the limbus, can actually present, seems like a Murren's ulcer because part of it grows towards the cornea and seems like an overhanging edge. This slide is from Dr. Santosh. This was one of the patients which we saw during our fellowship time. This was again an OSSN which is eroded intraocularly, and there was a perforation of the sclera with an uveal prolapse. So here the rest of the conjunctival and the scleral finding were missed, and this patient undergone a kind of a patch graft. And later on, when the disease became recurrent, that's the time when the diagnosis was made, and finally she had to undergo an enucleation. OSSN can actually be misdiagnosed as pterygium at times. So this patient definitely has a pterygium here. It's an atrophic pterygium. Same for this patient. This almost looks like an atrophic pterygium, a very flat placoid sort of thing with few intrinsic vessels seen if you see the patient under slit lamp. And here it's almost like a keratinized flat lesion on the limbus. Sometimes these lesions are referred as, especially in the younger patient, as Bitot spots also. So Bitot spot will have a lot of foamy appearance if you see under slit lamp, whereas this will be more of keratin, white keratin on the surface of the lesion. So this lesion needs to be, if there is a doubt, index of suspicion, we should go ahead with the biopsy. So what are the clinical characteristics which will tell us that, okay, we are not really dealing with a benign conjunctival lesion, but something more malignant. So you should look at the surface. If there is some abnormality of the surface, like if it looks a little more gelatinous, if it looks waxy, if it seems to have some surface keratin, that's the time we need to be suspicious that, okay, this is not a simple pterygium, but something else. If there are some abnormal blood vessels, either in the form of feeder vessels or in the form of some intrinsic blood vessels, that's again the time we need to be suspicious. Okay, this is not really a simple pterygium, but probably either an actinic change, which could be a pre-malignant lesion, or even an early OSSN. And we need to, staining with the rose bangle is probably make the diagnosis much more apparent, and these patients need prompt treatment. So I think I'll stop here for the sake of time.